Good afternoon, everyone, and welcome to our Spring 2016 CPTA Gen webinar. This is Leo Brando talking from Toronto, and for this webinar we are using the program called GoToWebinar to webcast this session. Before we begin, please allow me to go over some housekeeping details to assist in everyone's participation. For example, for the Q&A session to occur at the end of the presentation, if you are in front of a microphone and you would like to ask your question verbally to Dr. Mako Johnson, please click on the hand button found on the side of your control panel to raise your hand, and we will unmute you. You can also type into the question box of your control panel to send me the questions, and I will bring them forward to the presenter. Number 2, a quick reminder to our sick kids audience in the clinic conference room. During the Q&A session, we kindly ask you to come to the white microphone on the podium so that your question can be heard clearly to all participants. At the end of the session, an evaluation survey will appear at the end of the webinar. We please ask you to take a minute to complete this form. The survey will also be sent in a follow-up email to everyone that registered. At the end or during the session, if you require any assistance in participating or encounter a problem, please enter it on the comments question box. Alternatively, please feel free to call me directly at 416-813-7654 extension 205401. Now, without further ado, please allow me to introduce our esteemed speaker for the session today. To be honest, Dr. Marilyn Mako Johnson does not require any introduction. Marilyn has received her bachelor's in science from Penn State University and her MD degree in Thomas Jefferson University, still in Philly. She completed her training in pediatrics, pediatric hematology oncology, and pediatric hemostasis at the University of Colorado and Children's Hospital of Colorado, under the legendary wings of Dr. Bill Hathaway. After a brief stint as a director of the Hemophilia Center in Buffalo, Dr. Mako Johnson joined the faculty of University of Colorado, where she has served as director of University of Colorado Hemophilia Center. She has received several honors, including University of Colorado Faculty Council Award for Excellency, the U.S. National Hemophilia Foundation Kenneth Brinkhouse Award for Excellence in Clinical Research and Researcher of the Year, and an award by the CDC for Excellence in Research and Treatment in Hemophilia. She was also named as the Women Pioneer in Hematology by Novo Nordisk. Currently, Dr. Mako Johnson continues to serve as a professor of pediatrics and director of hemophilia and thrombosis service at University of Colorado and scientific primary investigator of the Athens CDC Community Counts project for surveillance of outcomes and complications of congenital bleeding disorders. We could continue on and on, but let's use our time more wisely because we can learn a lot from the experience Dr. Mako Johnson has on managing patients with fibrinogen deficiencies. And therefore, we open the floor for Dr. Mako Johnson. Thank you very much for agreeing to participate on this webinar, Marilyn. The floor is yours.
Thank you, Leo, for that lovely introduction, and thank you all of you Canadian hemophilia physicians and providers. I know many of you, and it's an honor to be able to present to you. This is a topic of great interest of mine, although it's a rare disorder, and what I'd like to do today is review the structure and function of fibrinogen, present case studies for afibrinogenemic patients whose care I've participated in, show how I've applied global assays to model hemostasis in these patients, compare some of these case studies with what's in the published literature, and then make a summary and conclusion of this. So the main points of this talk are that congenital fibrinogen deficiencies are rare, are very variable, and fascinating disorders. Individuals with mutations in the genes encoding for fibrinogen are striking in that they can be asymptomatic, they may have a bleeding disorder, they may have thrombosis, or they may show simultaneous bleeding and clotting. Due to the complex molecular structure and function of the fibrinogen molecule, it's difficult to predict the phenotype from clinical lab results. So the case histories, the mutation sequence analysis, and the global assays offer an opportunity to explore the impact of individual fibrinogen mutations to better understand this disorder. Okay. Well, the best known structure of the fibrinogen molecule is the formation of the fibrin clot, where the coagulation cascade of enzymes leads to the terminal enzyme thrombin, which cleaves fibrinogen to form the fibrin clot. But we also know that activation of platelets and formation of the procoagulant platelet surface with subsequent formation of the platelet plug is also critical to the generation of thrombin and to the formation of the fibrin clot. Now, we know that fibrinogen serves as the primary ligand to cross-link and stabilize the platelet plug via the glycoprotein 2B3A receptor that's formed in the process of platelet activation. Fibrinogen is therefore key to both the fibrin clot formation and the platelet clot, and these two entities form simultaneously and contemporaneously, and the fibrin clot being a contractile protein and then pulls down the net over the platelet red cell mass that forms. Now, we don't usually emphasize the other areas of cell biology in which fibrinogen is very, very important. Fibrinogen is critical to many cell matrix interactions. It binds with heparin, with fibronectin, and cell adhesion molecules. So fibrinogen enters into the interstitial space via vascular leakage during inflammation. And through this mechanism, fibrinogen participates in a wide range of physiologic biologic functions, such as angiogenesis, wound healing, and bone remodeling, as well as in many pathologic processes, including retinopathy, tumor growth, and pannus growth. In murine models, it's been shown that while fibrinogen deficiency does not decrease the growth potential of malignant clones, it does greatly decrease the metastatic potential and the number of metastatic lesions. This effect augments that of thrombin deficiency, in here modeled with hirudin, but is independent of thrombin. So this in panel A, this is a normal mouse with fibrinogen, and these are little metastatic clones that have developed. This mouse is a fibrinogen deficiency mouse, and you can see that it has far fewer mets, but the mets it does have are of similar size to the native mouse. And these graphs display the results, where in the fibrinogen replete mouse, you see a variety of numbers of metastases. And when the mouse is treated with hirudin, this is to decrease thrombin, this is greatly decreased. But in a fibrinogen knockout mouse, you see fewer metastases, and they tend to be much smaller, and the effect of hirudin is somewhat augmented. Now, the fibrinogen molecule is composed of two homodimers, each of which is composed of 3 individual peptide chains, which are called the fibrinogen alpha, beta, and gamma chain. The 2 heterodimers are joined at a structure at the amino terminal of the molecule, and this is termed the E domain, whereas these are the amino. The carboxy domain at either end of the molecule are called the D domain. Now, thrombin activates the fibrinogen molecule via cleavages of small peptides in the A alpha and B beta chain, generating fibrinopeptides A and B and allowing the initial polymerization of the molecule. This schema of Suchitra, Kyra, and Donna DiMichele shows cleavage of the D domain by factor 13 to cross-link fibrin and form the D-dimer structure, and that plasminogen and TPA also bind to the D domain to cleave the fibrin clot in the process of fibrinolysis. Now this is my rudimentary scheme of the fibrin clot. The fibrinogen molecule undergoes complex post-translational modification, including the formation of 29 intra and inner chain disulfide bonds, N-link oligosaccharides, hydroxylation, sulfation, and phosphorylation. Upon cleavage by thrombin, two fibrinogen molecules polymerize at the DD ends to form a single-strand fibrin. The single-strand fibrin molecules, which you see here, then associate laterally at the DE interface to form two molecule-thick protofibrils, and then these laterally associate to form multi-stranded fibrils. Factor 13 affects a transglutamination across strands to form the cross-linked stable clot that's resistant to plasmin digestion. The thrombin-activatable fibrinolysis inhibitor is a carboxypeptidase that also renders the fibrin clot resistant to plasmin digestion by stripping the lysine residues necessary for plasminogen and TPA binding. This beautiful schema of Mike Mosison and his colleagues in Wisconsin show how the fibrin monomers associate through the DD and DE linkages to form the protofibril and then the fibrin network. Primarily through the DD lateral associations, 2, 3, and 4 fibril strands will form branch points and develop the contractile mesh network that compresses the platelet and red cell thrombus. You can imagine how primary defects in the fibrinogen structure or the quantity can lead to a deficiency in fibrin clot formation. Likewise, mutations in the thrombin binding, factor 13 binding, or TAFI binding can inhibit the formation of a stable fibrin clot. Fibrinolysis is equally important to fibrin formation and both bleeding and clotting syndromes. This schema shows how the binding of plasminogen to the lysine residues of the cross-linked fibrin clot with selective TPA binding to that plasminogen which is bound to cross-linked fibrin. This generates the enzyme plasmin, which cleaves the stable clot into the fibrin degradation products. The D-dimer molecule that we measure requires prior cross-linking by factor 13 and then digestion by plasmin, and thus is a footprint of both complete fibrin formation and enzymatic dissolution. Now, Pi1 is the primary regulator of plasminogen activation by binding to TPA and limiting the amount of TPA available to activate plasminogen to plasmin, whereby only free TPA is functional. And I added here that activated protein C also participates in the regulation of plasmin activation by binding to Pi1, and thus it pulls the reserve of Pi1 available to bind and inhibit TPA and frees up more TPA, so that activated protein C functions as a pro-fibrinolytic protein. And then, of course, at the end, plasmin is inhibited by alpha-2 in plasmin. Now, fibrinogen is a 340 kilodalton glycoprotein. It's encoded by 3 separate genes, the fibrinogen gamma, alpha, and beta genes, and they are located contiguously on chromosome 4. Interestingly, they're in the order of fibrinogen gamma, alpha, and then beta, and the gamma and the beta are encoded from 5' to 3', while beta is encoded in an opposite direction. The fibrinogen disorders are characterized by variable expressivity, and thus patients can be asymptomatic, as I said, have bleeding, clotting, or both. It's interesting that genetic mutations that cause A or hypofibrinogenemia can be involved in any of the 3 fibrinogen genes. But the gene mutations in the fibrinogen alpha gene are primarily null mutations, including large deletions, nonsense, and splice mutations, while those involving the beta and gamma chain are more likely missense mutations. This schema from Nierman and Arbez shows the breakdown in which about 50% of all A and hypofibrinogenemias that have been sequenced are related to deficiencies in mutations in the fibrinogen alpha gene. And as I said, these are primarily the null mutations, while the other 50% are pretty equally divided between the gamma and beta chains and are more likely missense mutations. The regulation of fibrinogen is also unique. So it's a unique molecule having 3 genes, and they're clustered in a line. Their regulation is coordinated. So all of the 3 genes are up and down regulated together in coordination. These genes are class 2 acute phase reactant proteins, and that means that they are regulated by the IL-6 and glucocorticoid signaling pathway. And I learned in doing this that class 1 also involves IL-1 signaling, which fibrinogen regulation does not have. So the very first report of the congenital afibrinogenemia was in 1920 in a 9-year-old boy, and that was probably shortly after the coagulation proteins of fibrinogen were determined. But the first characterization of a gene causing afibrinogenemia was not reported until 2001. And this was in a Swiss family, and these black triangles show the fibrinogen alpha chain genes that are present on 3 different chromosomes. So these 2 brothers were silent carriers, and they have these dark hatched genes with a fibrinogen alpha chain mutation, and they each married women who had a different alpha chain mutation, resulting in 2 pairs of brothers with 3 different combinations of, or I guess 2 different combinations, 3 different genes causing afibrinogenemia. So this first case description already illuminated how complicated fibrinogen mutations are. So we characterize fibrinogen deficiencies as afibrinogenemia, hypo-dis, and hypo-dis. So afibrinogenemia means there's an undetectable level of fibrinogen that is defined as less than 10 milligrams per deciliter, and these patients can have bleeding or thrombosis. Hypofibrinogenemia is anything less than 150 milligrams per deciliter. Patients are reported to be able to have bleeding or a lack of symptoms. Dysfibrinogenemia patients tend to have normal levels of fibrinogen with a decreased functional amount, and they can have bleeding, thrombosis, or no symptoms. Whereas hypodysfibrinogenemia is that with a low quantity and an abnormal quality of fibrinogen, and they also can have bleeding, clotting, or no symptoms. Now, when you look at the literature, many of the early cases were defined using the Klaus functional clotting assay, and that's a relatively insensitive assay. So some of the discrepancies in the symptomatology of afibrinogenemia possibly are related to the fact that the patients below the limit of detection actually had more fibrinogen than true afibrinogenemia. In the literature, this incidence of these fibrinogen gene mutations are about 1 in a million. They're inherited as an autosomal recessive. And hypofibrinogenemia is a heterozygous form of afibrinogenemia and has variable penetrance. The manifestations are very similar to platelet-type bleeding and factor 13-related bleeding. There is umbilical bleeding, intracranial hemorrhage, mucosal bleeding, joint and muscle bleeding are really not prominent. Thrombotic episodes are being recognized more recently. Recurrent miscarriage is a almost universal occurrence in afibrinogenemia without treatment, and peripartum hemorrhage. So I want to present 4 case studies of congenital afibrinogenemia patients, and I'll first give a little summary of their bleeding and clotting and, symptoms and their outcomes. The first patient I dealt with had an intracranial hemorrhage, muscle and soft tissue bleeding, but he developed thrombosis, including a massive myocardial infarction, which involved the left anterior descending artery, coronary artery, and peripheral embolic lesions, and he passed away from a fatal intracranial hemorrhage. The second patient, so this was a male, also a male, had bleeding causing bone cysts, muscle, and soft tissue bleeds, no thrombotic episodes, and his outcome as a young adult now is chronic pain from the bone cysts following 3 surgical procedures, and he's on prophylactic fibrinogen replacement. The third patient, a young woman, had more prominent joint bleeding with also muscle and soft tissue bleeding. She developed as a young adult recurrent bilateral pulmonary emboli and line-associated DVT. She suffers from hip and knee arthropathy, post-thrombotic syndrome, and is on prophylactic fibrinogen replacement. The fourth patient, a slightly older young adult woman, had 7 events of intracranial hemorrhage and then suffered bilateral pulmonary emboli and line-associated DVT. She has a mild visual field loss from one of her intracranial episodes and is on continuous prophylaxis. So the mutation analysis of these patients, patient number 1 was not sequenced prior to his demise. Patient number 2 had a fibrinogen alpha gene mutation, and it was there were 2 gene mutations, one on exon 1 and one on intron 4. The one was a missense mutation and the other a splice site. So this was a compound heterozygous mutation. The functional class was undetectable, and the antigen was less than 5 milligrams per deciliter. The thrombin time and rectolase time were infinite. This was the second young man. The first young woman had also compound heterozygous mutations in exon 4 and intron 6, and these represented a nonsense and a splice site mutation. So these were 2 null site mutations, and this patient had less than 0.5 milligrams per deciliter fibrinogen, and again, very prolonged thrombin time and rectolase time. The final patient was the only patient who was homozygous for a missense mutation, but in this case, it did not cause a qualitative defect, but a lack of fibrinogen with infinite screening tests for the fibrinogen and the thrombin time. And I want to go a little bit more into the case studies of these patients. The first boy I met as a 2-day-old term male, born to a gravida-1 mom. He developed bleeding from circumcision that was severe enough to drop his hemoglobin by 3 grams and was also bleeding from his heel stick. He warranted a coagulation evaluation and had a very prolonged PT and PTT with normal platelet count, white count, somewhat elevated bilirubin, and was blood type O positive and Coombs negative. His factors were assayed, and he had normal levels for newborn for 8, 9, 10, 5, 7, and 2, but had undetectable fibrinogen by the Klaus method or at this point an immunoelectrophoresis. So he was treated with cryoprecipitate, diagnosed with congenital fibrinogenemia. The bleeding resolved, and he was discharged at age 13 days. As he grew up, during his childhood, he had recurrent muscle, joint, and soft tissue hemorrhages, and the most prominent in him were muscle bleeds. He was treated with cryoprecipitate. He was on a solid detergent-treated FFP trial and required approximately monthly infusions. He also developed chronic headaches that were very debilitating during his childhood. When he became a young teenager, he began to manifest vasculitic lesions of his hands and feet following the cryo or the solvent detergent FFP. These could last weeks after the infusions. And in one episode, he went to a friend's house and a big, friendly Rottweiler dog, big muscular dog, ran up and jumped on his thigh. He developed a quad muscle bleed, and he required 36 units of cryo to stop that bleeding episode, and subsequently developed these embolic lesions to his fingers and toes, which developed into necrotic infarctions. They were extraordinarily painful. He would require chronic narcotics. We had him evaluated by our immunology service. They looked vasculitic but failed to respond to steroids, to plasmapheresis, or to immunosuppressive therapy. And this is a picture of the vasculitic lesions of his toes. And you can see here the scars of previous vasculitic lesions that he had with previous episodes of treatment. So you can imagine as he got to be an older teenager, he became very frightened of the very long-term pain and disability following each treatment and became very reluctant to take treatment. And this was prior to the availability of the fibrinogen concentrate. So we sent plasma to 2 research laboratories. They happen to be Dr. Dennis Galanakis at State University of New York at Stony Brook and Dr. Irv Gelfand at the National Jewish Pulmonary and Immunology Hospital here in Denver. And both labs found no conclusive evidence for fibrinogen antibodies, for immune complexes with fibrinogen, or cryoglobulins. However, by age 19, he developed acute, horrible chest pain and shortness of breath. He was found to have a massive left anterior descending myocardial infarction and he required inpatient cardiac rehabilitation for an entire year to develop enough cardiac reserve to go about normal day-to-day life. However, he returned home, and at age 20, within a year, he developed a headache. He went to bed. This was a frequent event for him, but 20 minutes later, his grandmother found him dead in bed. We performed a post-mortem examination, and he had subarachnoid hemorrhage, a right frontal parenchymal hemorrhage, and interestingly, on post-mortem, he had bilateral renal arteriosclerosis, showing vascular disease of the kidneys, and then cardiomegaly and left ventricular hypertrophy from the previous MI, showing the sequelae of both fatal hemorrhage and fatal thrombosis in this very young man with afibrinogenemia. During his teenage years, I met another baby who presented with circumcision bleeding and was diagnosed with afibrinogenemia with a fibrinogen less than 5 milligrams per deciliter. This child was treated with cryo approximately monthly for soft tissue and muscle bleedings, and interestingly, he manifests no joint bleeding. But as a young teenager, 13, 14 years old, he developed ankle pain, and this was diagnosed as osteochondritis dissecans. He was playing a game called parkour, a sport where you try to take a straight line and follow it even if you leap over buildings or over obstacles. So it is somewhat traumatic on the ankles with jumping off roofs, etc. And we hypothesized that microscopic bleeding within his bones and in the bone marrow of his ankle bones had caused bone cysts that deteriorated and caused this osteochondritis dissecans. In the literature, there are reports of individuals with afibrinogenemia developing such bone cysts. He was treated with fibrinogen concentrate prophylaxis 2 to 3 times a week. He's undergone 3 surgical procedures for these bone cysts. He continues with significant chronic pain, but no bleeding on prophylaxis, and has no thrombotic episodes. The third patient presented at age 17 months, and this was a young girl who presented at a Well Child Care exam with diffuse hematomas of her scalp and her trunk. The father was in our American military, and the family was suspected of non-accidental trauma, but they did perform a coagulation workup, and evaluation showed that this baby had less than 0.5 milligrams per deciliter of fibrinogen, and the etiology of the bleeding was attributed to afibrinogenemia. Now, going back in her history, it did appear that she had a muscle hematoma following her 4-month DT immunization. And starting at age 5 years, she did have recurrent knee hemarthrosis and later developed recurrent hip hemarthrosis. In the literature, fewer than 25% of afibrinogenemia patients have hemarthrosis, but she did develop 2 target joints. She would have oozing with her tooth eruptions and later had mild problems with menorrhagia. She received fibrinogen replacement for bleeding episodes approximately monthly. She began with cryoprecipitate. She was on a pre-licensure study of fibrinogen concentrate, and then had some disruption when that was not available and had to go back to cryo for a spell. At age 23, she developed a cough and shortness of breath with difficulty breathing. She had not received fibrinogen for the previous 5 weeks, and she had an undetectable fibrinogen level in her blood at that time. We brought her to the hospital and did an evaluation, including a chest spiral CT, which showed multiple bilateral filling defects in her pulmonary artery, despite the fact that she had no fibrinogen in her blood. So we hypothesized that these pulmonary emboli must be cellular and must be comprised of red cells, platelets, and white cells with no fibrin component. She was treated with fibrinogen replacement as prophylaxis along with enoxaparin for 6 months. It was discontinued, and we intended to evaluate her approximately 2 weeks after stopping fibrinogen to look for any markers of hypercoagulability, but 8 days after discontinuing the fibrinogen replacement, she had a recurrent bilateral PE and developed a DVT, and then went on to have recurrent PEs on warfarin, on enoxaparin and aspirin, all of them given with twice-weekly fibrinogen replacement, and developed a left upper extremity line-associated DVT, which evolved into post-thrombotic syndrome. We monitored her with some of our global assays that I'll show you, with thrombin, antithrombin complex, the thromboelastogram, and thrombin generation. So she was finally stabilized on dabigatran and aspirin. She remained on that for about 2.5 years, along with twice-weekly fibrinogen prophylaxis. Then we were able to discontinue the anticoagulation and continue the fibrinogen replacement. So because of my unfortunate experience with the first patient, we were looking at markers then available, and starting in 2002 when she was 14, we were following thrombin, antithrombin complexes in an afibrinogenemic state. And you can see her baseline was normal. So the normal range goes up to about 3.5 to 4, and children tend to be on the lower side, between 1 and 2 nanograms per ml. And at the time that she was studied, her fibrinogen was 10 milligrams per deciliter from a residual of a previous replacement treatment. In 2004, she presented with a bleeding episode. Her fibrinogen was at her baseline less than 5, and now her TAT was up to 4.5. We gave her human fibrinogen concentrate, and an hour post-treatment, the TAT was up to 27. We continued to follow her. Here are some representative results. When she was 20, her baseline was now 13.7 TAT in her baseline state of less than 5 milligrams per deciliter fibrinogen. At this point, these were research observations. We decided not to base a clinical treatment on something for which there was not established evidence, but it caused a heightened level of concern following our experience with patient 1. And this time, she actually, it was at 21 when she presented and had an upper level normal level of the TAT, and she had now 15 milligrams per deciliter residual rather than none. So this may have accounted for having less free thrombin, but after a treatment with fibrinogen replacement, she again had a high TAT post-treatment. In 2009, she developed the pulmonary embolism, and her baseline TAT was high, and after treatment, no higher. And at this point, she had gone from 24 as a nadir to 162 milligrams per deciliter of fibrinogen, getting the human fibrinogen concentrate. She continued on prophy, and after a year of prophylaxis, her baseline trough level of TAT on prophylaxis was back down in the normal range, although we did see a rise after treatment with cryo. Several months later that year, we again determined that on prophylaxis, with a trough level of 40 milligrams per deciliter of fibrinogen, she had a normal TAT, which did again have a spike. And these spikes were seen after human fibrinogen concentrate or cryoprecipitate. So I'll briefly tell you about the fourth patient who presented with bruising in another country, was diagnosed with afibrinogenemia. At age 13, she had her first episode of intracranial hemorrhage. A few of these were provoked with mild trauma. One followed airline travel, and some were spontaneous. But she had 5 recurrences and then was placed on prophylactic cryo for 5 years. She was taken off cryo, and within a period of time, she developed a 6th recurrence and then was put on prophy for life. She came to Denver to undergo a study of half-life and recovery with fibrinogen concentrate and to make some recommendations about treatment. She underwent some of the global assays that I'll show you, and she was found to have subtle evidence of hypercoagulability. So based on the experience of patient 1 and patient 3, she was counseled about thrombosis and afibrinogenemia and recommended anticoagulation for procedures or surgery and the possibility of long-term prophylactic anticoagulation with prophylaxis. She declined this anticoagulation. She said, "Doctor, I've had 7 intracranial hemorrhages. I'm a bleeder, not a clotter." And 6 months later, she developed a line-associated DVT with bilateral PE. And did require 6 months of anticoagulation. So what did we learn using some global assays to model hemostasis in these patients? So some of these findings are subtle, and I'll try to point them out. So this is a thromboelastogram of patient 2, the teenage boy. You can see it's a complete flat line in his baseline state. But following a replacement with fibrinogen concentrate, he makes a fairly good fibrinogen clot with a pretty normal lag time. And you could understand that because the enzymatic coagulation cascade is intact, thrombin generation time should be pretty normal. However, we have developed a plasma clotting assay that we call the CLOFAL. And not unexpectedly, this is a normal control, a normal adult control, so you have a lag time. You quickly make a plasma clot, which is detected by optical density of clot turbidity. And then as the clot lyses, you see the turbidity resolve. In his baseline state, he had made no fibrinogen at all. However, during treatment, and I can't see the screen, so I'll have to read that these are both in the normal. I think they might be 150 and 190 milligrams per deciliter. You can see that he still makes a very poor clot. And this is with fibrinogen concentrate, and I'll show you this on another patient too. So clinically, the patients respond very well to the fibrinogen concentrate. They've gone through surgeries. It's prevented bleeding, spontaneous and traumatic bleeding events. So it's a functional clot, but it does not model the same turbidity as a natural fibrinogen clot. Dr. Mindy Grunsky, and so this assay was developed by Neil Goldenberg when he was performing his fellowship here. This assay was by Dr. Mindy Simpson, now at Rush Memorial in Chicago, and this is an assay of thrombin and plasmin generation. And here is the normal curve of a normal adult. And we do, in thrombin generation, and in children and teenagers, we generally see some delayed and decreased thrombin generation. That this patient, the teenage boy, looked very normal in his thrombin generation to a typical healthy teenager. But after receiving fibrinogen concentrate, he had a further delay in his thrombin generation, as if the fibrinogen did something to decrease or absorb the thrombin in his plasma. Interestingly, we saw in this patient almost no plasmin generation, and this reminded us that that plasma needs the fibrin scaffold upon which to bind plasminogen and activate plasmin. And in a fluid state, without a fibrin scaffold, there's essentially no plasmin generation. But after the replacement with fibrinogen, his plasmin curve, again, the solid line is the normal adult, and this dotted line is typical for what we would see for a healthy child. This is a euglobulin clot lysis time, an assay of clot lysis. Again, this is the normal, pooled normal plasma control. In his baseline state, he makes no clot. And in his replaced state, again, this is an optical density detection of clot, and it looks much more poor than the normal clot, but the lysis curve is at the same time as the normal. This is the young lady who developed the multiple PEs, and here where she got baseline state, makes a very poor clot that falls apart. Now, this is not her baseline state. This is about 40 milligrams per deciliter of fibrinogen after replacement. And after getting cryo, it's very subtle, but the lag time is a little bit shorter even than the control. And she, again, seems to have a short lysis time, but makes a better clot. After fibrinogen concentrate, she doesn't have quite as blunt or as steep an angle of the thromboelastogram, but she makes a good clot. And and in a way, if you look at these lines from the pre to the post, the delay is prolonged a little bit in the clot formation that goes along with what we saw in the thrombin generation. Again, in a baseline state, she made no clot on the CLOFAL compared to the normal curve, and being replaced to the normal range, these multiple curves show a much smaller clot curve than you might expect using the concentrate. Interestingly, in this young lady in the baseline state, and I think this might say less than 5 milligrams per deciliter of fibrinogen. It's a very little bit and very subtle, but rather than her thrombin curve being delayed and decreased as a young person, it's actually a little earlier than the normal adult curve with no plasmin. And then after receiving fibrinogen, she actually pushes her thrombin generation curve to a more delayed position. So it appears that these patients have earlier thrombin formation when they have no fibrinogen, which then becomes delayed when they're replete with fibrinogen. And again, although she makes a very poorly visualized clot, it looks as though her clot lysis is pretty normal. And the fourth patient would not tolerate going down to a very low fibrinogen level because of the previous 7 intracranial hemorrhages, but again showed that after fibrinogen replacement, she actually had a minimal prolongation of the lag time, but a stronger TED clot with a higher MA and a more steep angle of the clot. She had a short lysis time in the pre and the post. And she showed a fairly noticeable shortening of the lag time in thrombin generation. And this was despite the replacement that she was receiving with the fibrinogen concentrate. And yet her plasmin generation was pretty normal with replacement. So it was based on this early thrombin generation and short lag time that the history of other patients with thrombosis, now having been seen twice, were relayed to her. And if scientifically, it's I guess superior that we were able, without intervening, to see that this was then followed within 6 months with a clinical event. We did, this was patient number 3, we did a half-life study after cryoprecipitate. So the patient started with 10 milligrams per deciliter of fibrinogen and a normal thrombin antithrombin complex. And again, we see the slightly delayed and decreased thrombin generation consistent with a healthy young person. 30 minutes post-cryo, when the fibrinogen was now 84.5 milligrams per deciliter and the TAT was up to 27, we saw that the yellow thrombin generation line shifted to the left and now was noticeably earlier than the normal curve. At 24 hours post-cryo, it was kind of crossing the normal curve, and the TAT was coming down. 48 hours, the TAT, and you can see the fibrinogen is decreasing to 47, 36, and 13. And as the fibrinogen, after the cryoprecipitate, you can see as time went on, the yellow thrombin generation line progressively prolonged until it was back looking like the baseline state. So so what we did then is we took her plasma with no fibrinogen, and we then reconstituted it with 15, 26, and 120 milligrams per deciliter. So this is the green, the yellow, and the blue line, and the reds are the normal pooled plasma. And we found that she had that lysis progressively, plasmin generation progressively improved as we reconstituted fibrinogen. But all of the thrombin generation, the green, yellow, blue lines, were all shorter than the red normal control, and there was no concentration dependence, as if there might be some thrombin or thrombin activatable products, procoagulants in her plasma that were not immediately neutralized by this mixing study. Putting this together with the half-life study and with her serial studies before and after prophylaxis, we interpreted this to say that there is some function of fibrinogen which decreases thrombin generation and clot formation, whether it's the function of fibrinogen to be a sink for thrombin, whether free thrombin is pre-activating platelets, whether there are some other partially activated proteins in the plasma that serve as a catalyst, and that when these patients are given an episodic dose of fibrinogen replacement in cryo or concentrate, they have a short burst of hypercoagulability, and sometimes these are precipitated without any instant of replacement. But once they have a continuous level of fibrinogen in the hypofibrinogenemic level, this hypercoagulability did not seem to occur. Now, just to give you another frame of reference, this is data from CSL Behring's licensure study, in which we conducted half-lives on 15 patients with afibrinogenemia, and the fibrin monomer was used as a reference for hypercoagulability in these patients. And interestingly, the patients were all hypercoagulable by circulating fibrin monomer in their pre-infusion state, and this bumped at 1 hour, and actually was even higher at 4 hours, but decreased at a day and 10 days. So this is a different set of patients, a different hypercoagulable marker showing very similar results. So looking across at fibrin monomer, at thrombin antithrombin complexes, at thromboelastogram lag times, at time to thrombin generation, we can see a subtle evidence of hypercoagulability in patients with afibrinogenemia. Well, in the literature, there was a very nice series by Flora Pavandi and colleagues in 2006 in hemophilia, and she reported on 100 patients with fibrinogen deficiencies, of which 72 had less than 10 milligrams per deciliter. And interestingly, she found that 67% of the patients did not require prophylaxis, and they had a mean of 0.7 bleeding events per year, with a range of 0 to 16. So from no bleeding to very frequent bleeding. The patients I saw all averaged more like 12 events per year on demand. And a third of the patients were on prophylaxis, either for frequent bleeding or for life-threatening bleeding. And their rate of bleeding on prophylaxis was 0.5, so the range was much smaller, but their mean was not that much different from the patients on demand, showing that obviously these were the more severe patients, and they were rendered to be similar to the patients with a more mild phenotype. What results in this variability and why some of these patients don't bleed very much is completely unknown. I want to present just some fascinating information on heterozygous fibrinogen deficiency. And here's a null mutation with a father and mother of one of the patients. The father has a nonsense mutation. He developed a recurrent left calf DVT. His first clot was idiopathic in his 50s, and then he had a recurrence following a long duration car ride. His fibrinogen is at low normal. His antigen and activity are similar without a dysproteinemia. His dimer is negative in a baseline state. His thrombin time and rectolase time are just at the lower upper limit of normal, and his TAT is normal. He's on long-term anticoagulation now. His wife, who has a splice site mutation, so this is a null mutation, had a left calf DVT following surgery, and she also has a normal fibrinogen activity and antigen, and a very similar other screening markers, and she has had surgical bleeding and required fibrinogen replacement for the surgery. So she had bleeding in the surgery, and then following the surgery had a DVT as a hypofibrinogenemic patient. There's another family with a missense mutation, and there's one mutation in this family. It's a heterozygous alanine to asparaginine at position 315. The paternal grandmother had recurrent bilateral lower extremity DVT and never had bleeding. The father had a history of hemarthrosis in his right ankle and his left knee. He had right calf DVT twice, and he experiences recurrent upper extremity superficial vein thrombosis. He has a mild hyperfibrinogenemia, an elevated factor VIII, an upper normal D-dimer, and he's on warfarin with an INR of 2.1. So he has a normal TAP, but a slightly high dimer on warfarin. And his daughter suffered a perinatal arterial ischemic stroke with significant hemiplegic sequelae, and she has similar findings to him, although she's now a young adult, and her fibrinogen has progressively increased the fibrinogen activity with age, although she has not yet developed a recurrent thrombotic event. So the mutation in the last family was expressed, and it was modeled to be at a very critical site on the conformational change in the DD interface, which could predict that there would be enhanced DD associations because there was more energy released with the DD ends associating with this mutation. And this shows higher energy release in the mutant fibrinogen compared to the wild type. And when you look at plasma with a slight hypofibrinogenemia, the patient and the father have actually a decreased rate and degree of fibrinogen polymerization. But if you looked in a purified system, that had a slightly increase. Not convincing, but intriguing that maybe in the future we can identify these mutations, model their effect on the structure, look at predictions with energy transfers as to whether these would cause increased or decreased or tighter or looser associations, and try to predict bleeding or clotting. So to summarize, the bleeding phenotype does not predict the risk of thrombosis in these hypodysfibrinogenemic patients. And additionally, the genotype-phenotype correlation has really been difficult to establish for both bleeding and clotting. So to date, we have no clear relationship between a molecular defect and the bleeding or clotting risk, and we've had variable phenotypes even among siblings sharing a genotype. This has been reported by Demorlus in a nice review article in Seminars in Thrombosis and Hemostasis, although in one of our patients whose brother was relatively had asymptomatic, we found that he was probably a heterozygote with a failure to detect the normal gene. So congenital afibrinogenemia and thrombosis, would you use concomitant hemostatic and anticoagulant therapies? While I propose, and this is a review article done by Larissa Bornikova, it's very interesting, looking at 50 cases of congenital afibrinogenemia patients who've been treated, and whether they develop bleeding, thrombosis, or both, whether this was to prevent bleeding, treat bleeding, treatment around pregnancy and delivery, or treatment for surgery. And there was a very high rate of surgically associated thrombosis in these patients. So we recommend monitoring for laboratory and clinical evidence of coagulation, activation, and clot formation. At least we should consider prophylactic anticoagulation at the time of surgery and intensive fibrinogen replacement, unless a patient's been on continuous prophylaxis, which may change that risk. Some people give small doses of heparin with the administration of fibrinogen. In surgical settings, there have been used both compression stockings and low molecular weight heparin. And you could consider a direct thrombin inhibitor in the event of thromboembolic complications. And congenital afibrinogenemia may be an indication for long-term prophylaxis. In this paper, I just want to conclude that there was a reference to one gentleman who had very similar appearing embolic lesions to his toes, and he underwent vascular surgery. And at the time of surgery, histologically, it was found that he had a big unstable mural thrombus in the media of the femoral artery. And it appeared that he had an unstable clot, which would form, grow big, break off, embolize, have some bleeding in the mural wall of the artery, form another clot. And so it actually even makes perplexing the embolic lesions. Are these actually an unstable clot that's a sequelae of a bleed, or is it actually something we would consider a thrombosis? Kind of in the middle of both of them. So that are some of the thoughts I wanted to leave you with regarding congenital fibrinogen deficiencies, and I'm really happy to take questions. Thank you. Thanks for your attention.
Thank you very much, Marilyn, for this very challenging field in which it looks like we blink once, they bleed, we blink twice, the patient's clot, and God help us. Let's open the floor for questions. I'll start with centers that are identifiable in here. Going to the west, Calgary. Let me open the mic to see if there are questions from Calgary. Under Shaheen Damji. Looks like we don't have questions from there. Let's open the floor now to coming out east to Montreal. Let me open the mic of Montreal. I'm opening the mic. Questions from Montreal? Not necessarily. Let me open the questions for the floor at Sick Kids. Do we have questions in our room?
Yeah, I have. Can you hear me, Marilyn?
Yes, I can. Hi.
Hi, it's Manuel.
Yeah.
So I have two questions. One has to do with genetics, and the other one is just management of these patients. So all the cases that you mentioned of afibrinogenemia are situations where a patient has two mutations, and they're both on the same fibrinogen gene. So they're both on the alpha or the beta or the gamma. So what happens if a patient has two mutations, but they're not on the same gene, alpha and one gamma? I imagine that they behave kind of just like a heterozygote. Is that correct?
Well, it is true that could be an explanation for some of these patients who seem less symptomatic or asymptomatic in the literature. We just sequenced the patients that we have had access to, patients who have sought care here. I guess I would say that I would be very excited for any collaborations to look at any of these plasma assays and gene mutation analysis in any other patients or heterozygous affected family members, because I think the one afibrinogenemia patient whose both parents had thrombosis, and then the other hypofibrinogenemia family, and I didn't even bring that up, that no one has suggested that a simple hypofibrinogenemia should cause a thrombotic tendency. We're still trying to express and model that protein to see if it may be a type of dysproteinemia. But we have thromboses in 3 generations in that family. And I just want to emphasize that the global assays I showed are very qualitative. The changes are rather modest. To date, it's been very difficult to model hypercoagulability in global assays. And I would say that these findings in the afibrinogenemia patients are more striking than those that we've seen in other disorders, like, say, protein C or antithrombin deficiency. So it's more to pique curiosity, but I was devastated that the first young man had so much bleeding and then developed a massive clot. And so I looked for very subtle signs, and since most of our hypercoagulability is based on a fibrin clot, and these patients have no fibrin, we have to look at other indicators, and I just think that this is a clue that there's something going on.
So the other question that I had is, it's really when to start prophylaxis on these patients. I mean, the cases that you showed had such horrible both bleeds in the recurrent intracranial hemorrhage patients and also clotting. And from what you were saying, as long as you're on long-term prophylaxis, even the thrombotic potential seems to be abrogated if you're on steady state sort of long-term prophylaxis. So, like in Factor 13, we don't wait for events to happen. We put everybody on prophylaxis. Should we be testing for afibrinogenemia, or should we do it based on their clinical presentation?
I think you're exactly right, and all of these patients had symptomatic courses prior to the thrombosis. So the youngest patient is in his early 20s and did not perceive his once a month muscle and soft tissue bleeds to be important enough or damaging enough to warrant prophylaxis. And it was really when we made the association of the afibrinogenemia to his ankle pain that he adopted prophylaxis and stayed on it. It's intriguing that he did start our clots were all in young adulthood, all past 20. And so he started as a teenager and did not develop a clot. So I think you're absolutely correct. If patients are put on Profi for bleeding indications, they'll never manifest this thrombotic tendency. But for those patients who have bleeding, but it does not seem severe enough to warrant Profi, at least in the patient's perception, it may be worth looking for subtle evidence of hypercoagulability as another reason to do this. Actually, the fourth patient had a sibling who was a physician who came here and looked at all of our evaluations and advised the patient not to adopt prophylaxis based on these very subtle findings and the paucity of data in the literature that this is a thrombotic disorder. Well, actually was on prophylaxis, but not to adopt anticoagulation. And I actually, when the patient had some procedures, I had recommended prophylaxis, and both the physician sibling and the treating internist hematologist did not see the thrombosis as a credible risk, and the patient did develop bilateral pulmonary emboli after the procedure. So I think that this is an evolving field, and when these occurred, there was very little in the literature to support the thrombotic risk. So in the fourth case, where the patient was in her mid-30s, the thrombotic manifestation was in excess of prophylaxis. So I think maybe you need higher prophylaxis or targeted anticoagulation to surgery. So I think that just enough prophylaxis to prevent bleeding may not abort all of the thrombotic risk as we get older, as the patients get older. But otherwise, Manny, that's a good point, that if we just prophylax for bleeding, this may go away. There's another, in that 2011 JTH paper, there was another fascinating case of a woman with multiple intracranial hemorrhages. And one time she presented with a focal acute onset neurologic deficit, but CAT scan showed no evidence of blood. But based on her afibrinogenemia and her history, they determined she had to have an intracranial hemorrhage, and they gave her cryo. And then she developed a pulmonary embolus. And based on the pulmonary embolus, they gave her heparin and more cryo. And when they gave the heparin, the neurologic symptoms resolved. And they did not diagnose an arterial ischemic stroke, but I thought it was very intriguing that her initial episode may have been thrombotic. And she actually got worse with replacement until she was given anticoagulation. So I think it's something we should just think about with these patients when they're not behaving the way we think they should.
Thank you very much. Any other more questions from the floor at Sick Kids?
Yes, there's one other question. It's Lanny, one of the transfusionists here. What type of dosing do you typically use for the fibrinogen concentrate prophylaxis when you're using it on the patients, the children?
So in the fibrinogen concentrate study, we found the recovery was about, I think, 1.8 milligrams per deciliter in the plasma per milligram per kilo given. And based on that, to get a normal level for surgery, the recommendation of the package insert is about 70 milligrams per deciliter. Now, for patients on long-term replacement, they're generally using more like 40 to 50 milligrams per kilo twice or three times a week. And it just depends on their bleeding rate. But we just monitored thrombin antithrombin complexes and bleeding. And they seem to have tolerated a trough of about 40 milligrams per deciliter.
And is this given by the patients always in hospital or at home?
Or yes, they infuse it at home. It does, so it's, I believe it's about 50 mLs per gram, so it is a much larger volume, and we provide home infusion pumps to put the larger syringes on.
Mm-hmm. Okay. If there are no further questions at Sick Kids, let me quickly open the mic for Hamilton. Do we have any questions from Hamilton? Mihir?
No, we're good. Thank you.
Thank you. And the final to Halifax. Vicky, any questions? Maybe not. As we've passed the hour, I would like to thank Dr. Menko-Johnson again for sharing her wisdom on the issues of fibrinogen-related abnormalities. hoping to see everybody in the upcoming annual meeting in Vancouver. Thank you very much, Marilyn, and for all the attendees.
Thank you. Thank you very much. Bye-bye.
Bye-bye. Thank you.